Acute coronary syndrome and acute ischemic infarct both are big vessel disease. This can be a small vessel disease as well. If there is small vessels are involved, then that cause lacunar infarct. And here if small vessels are involved, then that also cause infarct. But that is not manifested like ST elevations. That is called non-ST elevation acute coronary syndrome. But here we are talking about big vessel disease. So what is the pathogenesis of these infarct or tissue necrosis in both big vessel conditions? Let's suppose there is any atheromatous plaque here in the right coronary artery. And when this ruptures, what happens that there is turbulence of blood flow. So when there is turbulence, then what happens? Clotting cascade is activated. So platelets come together, platelets adhere on top of one another, and on the clump of those platelets, clotting factors come and they start parting together, those clotting cascades. So one clotting factor activates another clotting factor, that activates another clotting factor, and that leads to thrombus formation. So one mechanism can be that new thrombus has formed and that has occluded the distal tissues. Or other can be that this ruptured plaque has dislodged and gone to the distal vessels and blocked the perfusion to the distal tissues. Similarly, in the CVA, cerebrovascular accident, same phenomenon can occur and can cause infarct of the cortical tissue. So, how can we treat it? So, what we have to do that, as I told you that platelets come together. So, we have to stop platelets coming together. So, we have to give drugs like antiplatelets. So, we give aspirin 300 mg initially. Why? To maintain high serum concentration. Initially, we give high dose. And after that, we can switch to aspirin 75 to 150 mg you can give daily. And other antiplatelets are clopidogrel, that we also give 300 mg initial loading dose and can change to 75 mg daily maintenance dose. So we stop platelet adhesions with these antiplatelet agents. And do you need to give anticoagulant in both cases? Here we give anticoagulant, but here we don't give anticoagulant. So why anticoagulant is required? You might be thinking that we have stopped platelet adhesions. So if platelet adhesions has stopped, then how clotting cascade will occur? Because that is the second cascade. On top of those platelet cell membrane, clotting factors come and adhere and starts activating one another. So if platelet adhesions has stopped in the first instance, so how does clotting occur? So why do you need to give clotting inhibitors or drugs that inhibit clotting cascade? Because with these drugs you cannot inhibit all platelets. You have 1.5 to 4.5 lakh platelet per mm cube in the blood. You cannot inhibit all platelets. So despite you have given antiplatelets, there can be clotting cascade. So to prevent that, to inhibit that, we give anticoagulant. So we give anticoagulant in acute coronary syndrome. Either if it is a small area infarcted or whole wall is infarcted, we give anticoagulant in both cases. But in case of cerebral infarct, we don't give anticoagulant because there is increased chance of bleeding in this case. So we don't give anticoagulant here, and there is randomized control trial has shown that there is not benefit in giving anticoagulant here unless there is some conditions like atrial fibrillations that predispose to thrombus formation. So to prevent next embolism, we can give anticoagulants but for treatment purpose we don't give anticoagulant in ischemic infarct, but here we give for treatment purpose. So these antiplatelet agents are not only for secondary prevention, but also it helps in treating the present acute condition.